Hello, everyone. My name is Jacqueline Dairo. I'm an MRI technologist at Sona Imaging Center here in Kenya. I have also had the privilege of serving as a program chair for the SWIM program, now in my second year. Today, I'm excited to share with you a presentation on diffusion tensor imaging, also known as DTI, where I'll be offering a radiographer's perspective on how we acquire the data, how we process it, and understand its clinical value. Let's start by looking at what DTI actually is and why it matters in our daily practice. Diffusion tensor imaging is an MRI technique that allows us to visualize the diffusion of water molecules in the brain and the spinal cord, particularly within the white matter tracts. It's based on how water moves differently along nerve fibers as compared to across them, and this property is known as anisotropy. For us as radiographers, understanding DTI is essential not only for acquiring technically sound images, but also for appreciating how our work contributes directly to diagnosing and managing complex neurological conditions. Our goal today is to break down DTI from both a technical and clinical perspective so that by the end of this session, we feel more confident in our ability to support its use in real-world practice. Let us briefly look at the history of DTI. Diffusion imaging started by simply observing how water moves through tissue. Then in the 1990s, this evolved into diffusion tensor imaging, which added something critical: direction. It wasn't just about whether water diffuses, but where it's going. Suddenly, we could actually see white matter tracks, not just infer their presence. That opened the door to fiber tracking, which now helps with things like pre-surgical planning and understanding how different parts of the brain are connected. Let's quickly look at the basics. MRI fundamentally relies on two types of tissue relaxation: T1, which reflects how quickly the protons realign with the magnetic field, and T2, which is about how quickly they lose their phase coherence in the transverse plane. These are the cornerstones of MRI contrast. Now, when we talk about diffusion-weighted imaging, we are adding sensitivity to the movement of water molecules in tissue, something particularly useful in like stroke imaging where restricted diffusion can be detected very early. So DTI takes these a bit further, and this is by assessing not just how much water diffuses, but also the direction it prefers to move in. And this is especially powerful in the brain, where it helps us map white matter tracts, giving us insights into the neural connectivity through tools like fractional anisotropy marks, which we'll look at a bit later, and tractography. Diffusion in MRI refers to the natural random motion of water molecules, what we call Brownian motion. These molecules move from areas of high concentration or where they are densely packed to areas of lower concentration. So now, in an isotropic environment, such as a glass of water, molecules will tend to move equally in all directions. But in an anisotropic environment, such as the brain white matter, the structure of the tissue restricts diffusion, and molecules tend to move more easily along the length of the axons rather than across them. This directional property is what DTI is built to measure. Understanding these will help us appreciate why DTI requires spatial pulse sequences and multiple gradient directions. So in short, it's all about capturing the preferred pathways of water movement in the brain. We've already seen how DWI can tell us if water movement is restricted, which is extremely valuable in cases like stroke or tumors. But here's the catch. DWI gives us just the magnitude of diffusion, not the full story of its direction. And that's where DTI steps in. Instead of applying gradients in just a couple of directions, we apply them in at least 6 directions. And this gives us a 3D dataset showing how water moves within each voxel of tissue. And this matters because in the brain, water tends to move along nerve fibers, and by capturing this directional data, DTI lets us map the orientation of these fibers, measure the integrity of white matter, and even trace the entire fiber pathways. Now that we understand how DTI builds upon DWI, let's go a level deeper into the core of DTI, the diffusion tensor itself. This is essentially a mathematical model in the form of a 3x3 matrix that describes how water molecules diffuse in 3 dimensions inside tissues. Each element in this matrix tells us how much diffusion is happening along and between each of the 3 main axes, the X, the Y, and the Z axis. Think of it like a detailed map of water motion inside each voxel of the brain. From this tensor, we extract 2 key measurements, the eigenvalues and the eigenvectors. The eigenvalues are numbers that tells us how much diffusion is happening along each main direction. And the eigenvectors will tell us the direction in which that diffusion occurs. And to visualize these, maybe imagine a football-shaped ellipsoid. And if water diffuses mainly along one direction, such as the axonal fibers, the ellipsoid will be elongated in that direction. The tensor gives us the mathematical blueprint for that shape. And here's the powerful part. Each voxel, every single voxel in the image gets its own tensor. And by combining these voxel by voxel tensors, we can start mapping the direction and integrity of white matter pathways in the brain. Now, this diagram shows the diffusion tensor as a 3D ellipsoid. The shape and the orientation of the ellipsoid reflect how water molecules move within a voxel. They are elongated when diffusion is greater in one direction and more spherical when diffusion is equal in all directions. The 3 principal axes, the X, Y, and the Z axes, represent the eigenvectors, and their lengths correspond to the eigenvalues. From our tensor model, we can calculate several quantitative values that form the backbone of DTI interpretation. First is fractional anisotropy. FA tells us how directionally restricted water diffusion is, and it ranges from 0 to 1. So 0 means completely isotropic or equal in all directions, while 1 means completely anisotropic or movement in just one direction. So high FA usually points to well-organized white matter fibers, while low FA might indicate conditions such as demyelination, injury, or edema. Next, we have mean diffusivity, or MD. So MD measures the average diffusion across all directions. High MD values can suggest tissue loss or increased extracellular space, which you might see in tumors or edema. And next we have axial diffusivity, or AD. AD reflects diffusion along the principal axis, essentially the largest eigenvalue from our tensor, and is often linked to the axonal integrity. And finally, we have a radiodiffusivity. Radiodiffusivity is the average of the 2 smaller eigenvalues representing diffusion perpendicular to the axon fibers. Increases here may point to myelin damage. So for us radiographers, knowing these metrics will help us detect if scan quality or artifacts might be present, which might end up influencing our results, so we can ensure we are giving out reliable, clinically useful data. Now that we have understood how diffusion tensors give us directionality, one of the most visually striking applications is tractography. This is essentially a 3D map of the brain's wiring created by connecting voxels that share similar diffusion directions. Here you can see examples of key tracts such as the corticospinal tract, which is crucial for motor control. There is the corpus callosum fibers, which link the left and the right hemispheres. And lastly, we have the arcuate fasciculars, which plays a key role in language function. There are 2 main approaches. So one, we have deterministic tractography, which is like following the most obvious path in a forest. So this is straightforward, but very sensitive to noise. And then we have probabilistic tractography, which accounts for uncertainty, especially useful in areas where fibers cross. So as radiographers, while we may not actually perform tractography analysis, our role is to ensure that the acquisition is of high enough quality to make accurate reconstructions possible. And this can be critical for neurosurgical planning, where precise fiber mapping can help avoid damaging important functional pathways. We've seen how tractography visually represents white matter pathways. So now let's connect these to its clinical value. So first, we use DTI. It's used in brain tumors, where surgeons use DTI to visualize the location of white matter tracts near a tumor. And this allows them to plan surgery in a way that avoids damaging critical pathways during resection. It can also be used in stroke and traumatic brain injury, and this can reveal subtle changes in white matter, even when the conventional MRI still appears normal. And this is especially valuable in cases like diffuse axonal injury, which can be very hard to detect otherwise. In multiple sclerosis, the DTI metrics such as fractional anisotropy and radiodiffusivity can sometimes help us pick signs of demyelination before we see the lesions on T2 or FLAIR sequences. It's also used in pediatrics and especially more now in psychiatric research, where it's being used to study the white matter changes in conditions such as schizophrenia, although this is still largely investigational. And DTI is also used to assess white matter development and detect abnormalities in conditions such as cerebral palsy or autism spectrum disorders. DTI protocols may look slightly different depending on the scanner vendor, but the core principles remain the same. First, B-values determine the strength of the diffusion weighting. We typically use around 1,000 seconds per square millimeter in clinical work, but research studies may go higher for more sensitivity. Second, the number of diffusion directions is crucial. While you need a minimum of 6 for a basic tensor calculation, most clinical protocols use between 20 and 64 directions to improve the accuracy. And third is the voxel size. So the voxel size matters. We aim for about 2 to 3 millimeters isotropic voxels. Remember, they have to be isotropic. Thinner slices will improve resolution but extend the scan times, which can increase the risk of motion artifacts. And fourth, the scan time itself is of course a balancing act. A standard scan can take about 5 to 10 minutes, but more directions or signal averages will extend that time. So fifth is the field strength, and this plays a big role. So 3T systems offer better signal and resolution, but with careful optimization, DTI is still very much possible at 1.5T. So as radiographers, our role is to just tailor these protocols to the clinical question to optimize the quality while keeping the scan tolerable for the patients. So here is just a few tips on how to actually set up the patient. So in DTI, we are looking at the very subtle directional movement of water molecules. And this means that any movement, even slight movement, can seriously degrade the image quality. So we'll start by making sure the patient is comfortable, warm, and well supported so that they can remain still. So always use a high channel head coil when possible, because this gives us a better signal to noise ratio, which is critical for diffusion imaging. Make sure the coil is properly tuned and centered over the head of the patient. So also take time to educate the patient before scanning. Explain what DTI is in simple terms, stress the importance of keeping still and let them know that the scan may take longer than usual, and also warn them about the loud noises from the gradients. So also use foam pads or inflatable cushions to minimize head motion. In pediatric or on uncooperative patients, sedation may be necessary. So always coordinate these with the anesthetist in these cases. For positioning, The patient should be supine, head first, with the head straight and centered, and the orbitomental line perpendicular to the bore. Misalignment here can distort tractography results, so ensure the patient is very much well-centered. So finally, the environment really matters. A quiet, calm space improves cooperation, and if possible, provide noise-canceling headphones and a squeeze alarm so that the patient feels safe and in control. So in DTI, artifacts are common and can easily compromise the diagnostic value of the study. So it's crucial to recognize them and know how to address them. I did not include any images of the artifacts in these slides, so please make sure you go and look for these artifacts so that when you see them, you can spot them and know that they are actually artifacts and know how to deal with them and to correct them. So the first artifact is motion artifacts, and these are the most frequent. These are seen especially in children or patients with cognitive impairment. They appear as blurring or ghosting. And the best strategies here include good patient padding, clear coaching, and using faster sequences, which with DTI might not always be possible. So if necessary, please sedate the patient. We also have eddy currents, and eddy currents happen because of the rapidly switching gradients in diffusion sequences, and this leads to geometric distortions, especially in API-based scans. So the solution to these is to use eddy current correction software during post-processing and to also take advantage of the scanners with built-in compensation. Next, we have susceptibility artifacts. So susceptibility artifacts tend to occur near the sinuses, the petrous bones, or near metallic implants. They show up as signal loss or geometric warping, and you can minimize them by using parallel imaging to shorten the echo train length, or by opting to use a shorter TE. But always remember that these will eventually affect your image. So be careful while adjusting all these parameters and know what you're compromising and what you're causing the image to look like. Then we have ghosting. These are face encoding artifacts caused by inconsistencies between even and odd data lines. Preventing them involves regular quality assurance of the gradient hardware, plus good shimming and coil tuning. So as radiographers, there are 3 golden rules that you must always keep in mind. First is to check the raw images immediately after the scan, and if you spot artifacts, repeat the scan or notify the radiologist promptly, and together then you can make the decision if you do need to repeat the scan or they can make do with the images that you have. Second is familiarize yourself with your scanner software, especially the software correction tool, so that you can apply them and fix the issues on the spot as you scan. Once our data is captured, it's not immediately ready for interpretation. It needs to be post-processed. So this is done using specialized software that takes the diffusion signals from the 6 or more directions and fits them to a mathematical model called the diffusion tensor. So from this model, we generate several maps, as we mentioned earlier. The fractional anisotropy map, which tells us how directional the water diffusion is in each voxel. The MD map, which shows the average diffusion rate regardless of the direction. And the radio diffusivity, which reflects diffusion perpendicular to the fiber tracts. And also the axial diffusivity, which measures it along the fiber direction. So we can also create color FA maps, where color encodes the primary diffusion direction. So for example, for red shows us the left to right, green will show us front to back, and blue will show us head to toe. So with tractography algorithms, we can then follow the principal diffusion directions across voxel to map out the brain's fiber pathways. Your site may either use commercial or even open source software for these, which are available for free online. So as radiographers, we are at the heart of ensuring high-quality DTI scans. One of the key responsibilities is adjusting scan parameters. For clinical DTI, these often mean selecting p-values between 800 and 1,000 depending on what you're using at your facility, choosing the right number of directions, which should be at least 6, but ideally 15 to 30 or more, and along with setting the right resolution and averages depending on the patient's tolerance and the scanner's capabilities. So quality assurance is just as important. And some of the questions that you need to ask yourself when you're scanning is probably, does the scan cover the entire brain? Does it need to cover the entire brain? Are there motion artifacts and how can you correct them? Are there any other artifacts and how could you correct them? Is there stable signal across all diffusion directions? These checks can make the difference between usable data and a failed study. DTI is also a team sport, really. Many planning decisions require collaboration with radiologists and the physicist, so maintaining open communication is essential. And of course, our interaction with the patient can directly affect the scan quality. So clear explanations help the patient relax and stay still during the scan. Lastly, we are educators, not just for patients, but also for junior colleagues and multidisciplinary teams. So sharing what you know, stay curious, keep learning, and keep doing your best. Well, DTI is a powerful technique. It's important to be aware of its limitations. First, the scan times can be very long, especially if we use high numbers of diffusion directions and small voxel sizes for better resolution. These not only increases our patient fatigue, but also raises the risk of movement during the scan because the patients get tired. DTI is extremely sensitive to motion, so even minor movements like swallowing or a small head shift or even repositioning of the head can introduce artifacts and compromise the entire data set. And this is particularly problematic when imaging children or patients with cognitive challenges who may struggle to remain still and follow instructions. From a modeling perspective, DTI uses a single tensor approach, which assumes that each voxel has one primary fiber direction. In reality, though, many voxels contain multiple crossing or diverging fibers, so advanced techniques are needed to fully capture that complexity. And finally, DTI should be viewed as complementary. It adds valuable information, but does not replace anatomical MRI, functional imaging, or even clinical judgment of the healthcare team. Knowing these limitations will help us use DTI wisely and interpret it in the right context. And that brings us to the end of my presentation. I hope you learned something about DTI and that you guys will be trying some of these out from your facilities. Thank you so much for your attention and feel free to ask any questions that you may have. Thank you and best wishes.